Okay, so you've given us some fascinating material to dig into here. We're looking at articles focused on direct primary care DPC and this really big problem of physician burnout.
Yeah, it's definitely a hot topic.
Right. So our plan for this deep dive is to really get a handle on what DPC actually is, why it seems to be growing, and maybe whether it's a real solution based on what these articles say.
And it's worth noting, these articles are mostly coming from the perspective of doctors who are actually thinking about making this change.
Which is a great viewpoint, right? Seeing it through their eyes.
Exactly. The people wrestling with the challenges day to day.
Okay, let's dive into the problem first. Burnout. The articles hit hard with that AMA statistic. What was it? 63% of doctors reporting burnout symptoms in 2022.
63%. It's huge. And the articles really stress this isn't just about being tired from long hours.
No, it sounds much deeper. Systemic stuff.
Totally. The argument is it's baked into the system. Things like, endless documentation.
Ugh, the paperwork.
Right. And then low reimbursement rates, feeling like you've lost autonomy over care decisions, and that constant pressure to just churn through patients. Faster, faster.
Yeah, 15-minute slots, sometimes less. It sounds like it chips away at the whole reason people go into medicine.
That's exactly what the articles suggest. They talk about this erosion of purpose, particularly for primary care docs, feeling like you just can't practice medicine the way you want to or the way you think is best for the patient.
It really paints a bleak picture.
It does, but that's kind of the setup for introducing direct primary care as a potential alternative.
Okay, so DPC, it's pitched as a different approach.
Yeah, a fundamentally different model. The idea is shifting away from that volume-based fee-for-service treadmill.
Which just seems to be driving a lot of the burnout.
Exactly, and moving towards a model that's really centered on the doctor-patient relationship.
Okay, so how does that work practically? Like the mechanics of it?
Well, the core idea is the membership fee. Patients pay a set monthly amount directly to the clinic.
Directly, so bypassing insurance.
For primary care services, yes. That direct financial relationship cuts out a lot of the administrative overhead and complexity that comes with billing insurance.
Right, which must change the daily reality for doctors quite a bit. The articles mention needing to see, 25-plus patients a day in the old model?
Yeah, or even more sometimes, just to make the numbers work. DPC flips that. Because revenue is more predictable from the monthly fees, they don't need that sheer volume.
So they can have smaller patient lists. Panels, they call them.
Exactly. The typical DPC panel size mentioned is often capped somewhere between, say, 400 and 600 members. Compare that to thousands in a traditional practice.
That's a massive difference. But managing a smaller panel, does that bring different pressures, like keeping those members happy?
That's a really good point. Yes, absolutely. While you lose the volume pressure, you gain the pressure of demonstrating ongoing value to retain those members. Patient satisfaction and engagement become even more critical. Your income depends directly on keeping those members signed up.
Makes sense. So smaller panels, membership fees. What are the big benefits this unlocks, according to the articles? For doctors, and I guess indirectly for patients too.
Well, the most obvious one is time. Longer appointments. We're talking 30, maybe even 60 minutes.
Wow, compared to 10 or 15.
Huge difference. It allows for actually digging into issues, building rapport. Then there's access. Same day or next day appointments become much more feasible when you have fewer patients overall.
Okay, that sounds appealing from a patient perspective.
Definitely. And also direct communication, like being able to message your doctor directly without going through layers of staff or needing prior approvals. It just streamlines things.
And you mentioned the admin burden. This model reduces that.
Significantly. Less time spent on coding, billing, fighting with insurance companies. That means fewer administrative staff needed, lower overhead.
And more time for actual clinical work.
That's the idea. Or, as you touched on, maybe reinvesting that saved time into deeper dives on complex cases, or continuing education, or even just, breathing room, which ultimately benefits patient care too.
The articles also mention transparency in pricing for patients. That's often a big frustration point.
Oh, absolutely. Because you're paying that monthly fee, you generally know exactly what your primary care costs are. Much more predictable than navigating copays, deductibles, and surprise bills.
Okay, so it sounds like a compelling model on paper. Is it catching on? Are we seeing real growth?
The data suggests it is. The articles cite the DPC Mapper, which tracks these clinics, showing over 1,600 active DPC practices in the U.S.
1,600. Is that a lot? Is it growing fast?
It seems to be steadily growing, and interestingly, it's not just in big cities. The articles point out expansion into suburban and even rural areas, which is quite telling.
And who's making the switch? Is it new doctors or...
It seems to be a mix. The articles highlight a few groups. You've got mid-career physicians, maybe feeling burned out in hospital systems, or large groups looking for an exit.
Okay.
Then you have some existing small private practices converting over to the DPC model, maybe trying a hybrid first.
A hybrid, like some insurance, some DPC.
Yeah, possibly as a transition. And then there's this interesting group building what they call tech-forward micro practices. Really small, lean operations, often leveraging tech heavily.
So it's described as a structural shift. That sounds pretty significant.
Right. It suggests it's not just a temporary fix, but maybe a more fundamental rethinking of how to run a practice sustainably, both financially and personally for the doctor, aligning the money with well-being.
But it's not all sunshine and roses, right? The articles do caution that it's not a magic fix.
No, definitely not. They're quite clear about the challenges. It's a big shift.
Like what are the hurdles?
Well, first, you have to educate patients. This is a new model for most people, so you really need to explain what it is, what the value is, how it's different from insurance.
Building trust outside that familiar insurance system.
Exactly. That takes effort. And then there are the practicalities of running the business.
Right, you mentioned less admin, but some things still need doing.
Precisely. Billing, even if simpler, still needs handling. Patient intake, communication systems. You're responsible for setting all that up or outsourcing it effectively. The buck stops with you, essentially.
And marketing, that came up too.
Yeah, big time. You have to think like a small business owner. You need to actively market your practice so people can find you. Medical school doesn't usually teach you that.
No kidding. And the articles actually say that failing to get that part right, attracting and keeping patients, is why some DPC transitions don't work out.
It's a critical piece. You need a plan. You can't just hang a shingle and expect patients to flood in, especially with a model they might not understand initially.
So if a doctor listening is feeling that burnout, how do they know if DPC is even right for them? The articles had some pointers for that, didn't they?
They did. Kind of a self-assessment guide. It suggests DPC might not be a good fit if, say, you don't actually enjoy building those deep, long-term patient relationships.
If you prefer volume.
Yeah, or if you think volume is the only way to succeed financially. Or if you're really resistant to tackling the business side of things, the marketing, the operations.
That makes sense. And conversely, who is it potentially good for?
Well, it seems ideal for doctors who really crave that deeper patient connection, who are ready and willing to shrink their panel size to focus on delivering really high-value care.
And motivated to rebuild, maybe with a new sense of purpose.
Exactly. And crucially, someone who understands they might need support to make that transition work. The hybrid model was also mentioned as maybe a less abrupt starting point for some.
Let's talk a bit more about that marketing piece. The articles emphasize it's about clear communication, not hard selling.
Right. It's about education. Patients need to understand exactly what's included in that monthly fee, what services are covered, how does the billing work.
And maybe just as importantly, what's not included.
Absolutely critical. DPC usually isn't a replacement for comprehensive health insurance. It doesn't typically cover hospital stays or specialist care or major surgeries. That needs to be crystal clear.
So managing expectations is key.
Yeah.
And communicating the benefits.
Yes. Why should a patient choose this? You need to articulate the value prop, the better access, the longer appointments, the price clarity, that personal relationship.
And just basic visibility, right? People need to know you exist.
Fundamentally, yes. If they can't find you, none of the rest matters.
The articles also mention support systems. Something called the Accelerator was named as an example. What's the role of resources like that?
Yeah, they're presented as ways to help doctors, especially those feeling burned out, navigate the whole transition without having to invent the wheel.
So practical help.
Exactly. Things like helping doctors set up their website and craft their message so it clearly explains DPC, strategies for attracting patients through online search, local networking, referrals.
Okay, the business development side.
Right. And building trust even before someone signs up, maybe through automated educational emails or a really smooth onboarding process, and helping them become less dependent on, traditional healthcare platforms that might not fit the DPC philosophy.
So it's about providing the tools and the roadmap for those non-clinical things that are essential to making DPC work.
That's the idea, empowering them to build a practice that's sustainable and lets them focus more on the medicine, regaining control, essentially.
It really leads into the concluding thought in the articles, which I found quite powerful, reframing burnout not just as an endpoint, but maybe a trigger for a rebirth through DPC.
Yeah, it's a hopeful message that burnout doesn't have to mean leaving medicine entirely.
Yeah.
It suggests that with the right approach, the right message, support, strategy, doctors can rebuild their practice and maybe their career on their own terms.
Okay, so wrapping this up, this look at direct primary care shows it as a really interesting potential response to physician burnout.
Definitely. A big shift from volume and insurance hassles to relationships and membership fees.
Yeah, offering potential wins like more autonomy for doctors, less admin, deeper patient connections, but clearly not without its own demands.
Right. It requires that shift in mindset, becoming a business owner, actively educating patients, marketing effectively, building trust differently. It's a significant undertaking.
It really makes you reflect on what matters most in healthcare delivery. Thinking about everything we've discussed, what aspects of DPC really strike you as addressing the core challenges we see today for both doctors and patients?
That's the key question, isn't it? Where does this model truly hit the mark? And for anyone wanting to dig deeper, the articles mentioned resources like the DPC Mapper to find clinics and organizations like Roxford Digital as examples of support providers.
And it leaves us with a bigger thought, perhaps. Given all these systemic pressures we talked about beyond models like DPC, what other, maybe more fundamental changes might be needed across healthcare to really tackle burnout and build a system that works better for everyone?